Dr. Jagiasi, from the definition, we now move to the management, the key component. And ventilation, as you all know, mechanical ventilation is one of the most key component of managing an ARDS patient. We have evolved from a lot of concepts. So we will concentrate on two concepts which has been, in and out, which has been coming up in the last 1 decade or so. So of that, the driving pressure, that's a critical in managing a ARDS patient. So how does it guide ventilatory strategies?
So when you look into when you speak about the driving pressure, actually what we are looking into is, we all know ARDS is a problem where the lung is affected, lung is injured, and we don't want to injure it more. So when you talk about the ventilator-induced lung injury, so there were many components which came in. It was volute trauma, it was barotrauma, then athlete trauma, that is biotrauma, and also there was something called as ergo trauma which came in picture. So there was quite a bit of fight amongst the pressure versus the volume, whether it's the pressure which is causing a problem or it's the volume which is causing a problem. And the baby lung concept was also coined by Gattinoni. They basically conducted a CT scan of the ARDS patient, and they found that it was not about the stiff lung what we initially thought of. It basically the loss of the lung volume. So the majority of the part is elastic. Elasticity of the lung is not lost. It's just the certain areas are damaged, and this is why the concept of the baby lung came in when they highlighted the gentle treatment. So with all those, the impedance came in picture, where we realized the forces that impede ventilation include non-elastic or the respiratory system resistance, and then the various pressures came in: airway pressure, P plateau pressure, transpulmonary pressure, driving pressure we've been talking about, and the intrinsic P. So from the fight between the pressure and volume, it went down to the stress and strain. So this is what we all started talking about. So stress is actually the lung stress, which refers to the pressure which is required to distend the lung against the counter force which is exerted by the various mechanism. Could be the airway resistance or could be the chest wall resistance. And the strain is again related to the stress and refers in change in the lung volume is what the strain is. So this is where the concept of the driving pressure came in. And meta-analysis was conducted by the MR2 of around the 9 RCTs, where he found out when he was looking into the difference in the plateau pressure and the PEEP. This is what the actual driving pressure is, and this is what we are talking about. So he found out when the difference was more than 15, there was a positively association with the higher mortality. So he also conceptualized, if you allow me to share one more slide, I will show you with all those RCTs. So he came out with a beautiful chart. 1 second, let's open it up. Yeah, if you look at this, if you see this, it has the different charts available. So the number one, if you see here, the PEEP is constant and the plateau pressure is rising. So of course, the difference in between two is more. So as the driving pressure rises, you look down, the mortality goes up. Then if you look into the second chart, here, as the plateau pressure goes up, the PEEP has also been increased, and they maintain the constant driving pressure. The difference in between the plateau pressure and the PEEP is being maintained constant by increasing the PEEP as the plateau pressure goes up, and the mortality remains stagnant. It remains static. They have tried to control the mortality. And if you look into the third, here the PEEP is going, plateau pressure remains a constant, but they have increased the PEEP. So overall, the driving pressure has come down and the mortality comes down. So this is what was important, and this is what he thought of. This could be the very important component of the stress and strain, and this is where we have to play a role in this, and we have to work on this significantly. And this is where the figure of 17 came in, and the majority of the randomized control trial lung safe study is a multi-centric international study which is being conducted, and it was to conduct the information. So they also documented in that the patient which had the difference between the plateau and the PEEP were less than 15, they had the better outcome, and the survival rate was better. And the notion again gained strength when the Bellini et al. In the retrospective study also demonstrated higher driving pressure was associated with the higher mortality. So this is how the concept of driving pressure is coming. And now the major, of course, this is not part of the major guideline. The reason being is the major RCTs are being underway as of now, as we are talking, and maybe there'll be one published in maybe 6 months' time, which will tell us how the driving pressure is going to come in and what exactly the numbers we should be following it, whether less than 15, less than 14, or less than 12. And how do we achieve those numbers? Also, they're going to demonstrate that. And also, they'll be working on driving pressure in the lateral position and driving pressure in the prone position. So these are the areas what we are looking into and eventually will come in play. So it will become an integral part of our ventilation modality. And the difference between the plateau pressure and positive pressure will what eventually we will start monitoring it. But of course, it has to be done in the absence of the spontaneous ventilation.
Thank you for highlighting the key concept of what we call as a safe ventilation. Now we are moving towards getting more safer because the baby lung concept, whatever you're talking about, more safety is more the key in survival. That is why the new concept of the mechanical power came into being. So could you please highlight about what is your idea about what you're thinking about the mechanical power in ARDS patients?
So as I mean, it's a good question to have. So as we also spoke about the driving pressure, the mechanical power. I've been talking on this in last 2 years or so, and my first talk was Dr. Monalisa only at Bhubaneswar. I given this talk on the mechanical power. So as he spoke about, there are various pressures and techniques and the volume techniques. So it's not only the pressure and volume which is playing a role. When we mechanically ventilate the patient, it's the overall energy which is being supplied to the patient. So apart from the pressure and volume, also there are dynamic characteristics like flow, frequency, rate, what we set, and the strain rate. So flow may be considered at the rate at which the given strain is occurs to the lung. And frequency, if I talk of suppose the pressure at suppose I take it arbitrary pressure maybe of 30, which is dangerous once, it could be more dangerous for 15 times. So technically, if I am giving that pressure the rate of 8 or the 8 times in a minute, if I give the same pressure for 15 times in a minute, it will be more dangerous. So this is how the concept of the mechanical power and came in. So basically it's the energy which is derived by the ventilator to the entire respiratory system, combining all factors of energy load, which includes the respiratory rate, pressure, tidal volume, flow rate, everything. So this was also considering all this, Gattitoni, he basically calculated and he coined an equation which is called as mechanical power equation, which takes all these factors into play: the resistance, elastance, flow rate, and also the respiratory rate. And it's a complicated equation which comes in. And with that, they calculate. Suppose the work is power into volume, then the power is the rate of energy spent, that is work into the respiratory rate. So overall energy would be the power into volume into the energy spent, and there's a whole lot of a complicated equation what it comes into. So all these dynamic factors play an equal role. So if what they say is doubling the tidal volume will increase the mechanical power by fourfold. Doubling the respiratory rate will increase the mechanical power by 1.4 fold. Doubling the peak will increase the mechanical power by 2-fold. So with all that equation, they calculate mechanical power per minute. So as of now, it's an all concept which is coming into the play, and we cannot calculate it. There has to be the AI-based calculation which the ventilator will tell us, considering all this into point. And but what they have concepted is power of less than 22 joules per minute is going to be the beneficial to the patient. If you go beyond 22 joules per minute, it might harm the patient. But again, it's a concept. It's not really come into the practice.
Thank you so much for answering the two critical questions very clearly and very with a lot of evidences. And the PPT is definitely PowerPoint slides is a added benefit for the viewers to see that. Thank you, Dr. Bharat.